the visiting staff of Department of Urology, Kaohsiung Chang Memorial Hospital. The title of his presentation today is Comparison of Robot-Assisted Radical Prostatectomy and HIFU for the Treatment of Prostate Cancer. Please start.
Thank you for the introduction. I'm Yang Liu from Kaohsiung Chang Memorial Hospital. Today it's my honor to share our experience about the comparison of robotic assisted radical prostatectomy and high-intensity focused ultrasound for the treatment of prostate cancer. We all know that the radical prostatectomy is now the standard treatment for localized prostate cancer, but the postoperative morbidity such as urinary incontinence and the erectile dysfunction is concerned. Recently, the robotic assisted radical prostatectomy provides the less intraoperative and the postoperative complications than the open RP and the laparoscopic RP, and may provide also provides possible better functional outcomes. So the evidence is not strong enough. On the other hand, high-intensity focused ultrasound, so-called HIFU, is a minimally invasive therapy with acceptable oncological outcome and less postoperative morbidity. But currently, the guidelines only recommended HIFU in clinical trial setting, EAU guideline, or as salvage treatment after radiation failure, NCCN guideline, due to lack of comparative studies with standard treatment. So we would like to conduct a retrospective single institutional comparison for IRP and HIFU in a localized prostate cancer with respect to the oncological and the functional outcomes. The patient selections, this is a retrospective review from the April 2015 to the June 2018. And the patient with localized prostate cancer, which is equal or less than T3A N0M0, undergoing HIFU and IRP as primary treatment in Kaohsiung Chang Memorial Hospital. We exclude the patient with the previous treatment or pathology other than the adenocarcinoma. In the IRP group, we use the Da Vinci SI surgical system, and there are 6 surgeons and 51 patients. We use a transperitoneal approach. And in the HIFU group, we use an ablation integrated image system. And there are also 6 surgeons and 123 patients. Among the patients, whole gland HIFU number is 118. Focal HIFU is 5. And we perform the routine preoperative TURP before HIFU. The definition for the PSA biochemical recurrence for IRP group is PSA more than 0.2 ng per milliliter. For the HIFU group is PSA more than nadir plus 2 ng per milliliter. And the de novo erectile dysfunction is defined by the patient with preoperative IIF5 equal or more than 17, but the postoperative IIF5 is less than 17. And the urinary incontinence was defined by the PET use at the last follow-up. Here is the patient's characteristics. We can see that the patient of HIFU is older than the patient of IRP with significance. And the patient's the IRP patient have high proportion of the T stage more than T2B, which is about 70%. And the patient of a high risk patient has high proportion about 78.5% in the IRP group, and no patient was low risk. And the proportion of different risk is significant. Except these parameters the other parameters were comparable. In the oncological outcome comparison, we can see that the follow-up duration is about 2 years, and the PSA net is much lower in IRP group, which is 0.1, and the HIFU group is 0.9. And we can see that the PSA biochemical recurrence-free survival was longer in the HIFU group, but may be influenced by the different proportion of the risk group. So we analyze the subgroup of the patients by the risk. And the salvage treatment in overall or low, intermediate, high risk was comparable between the two groups. And also the metastasis and mortality rate was similar. Here is the Kaplan-Meier analysis for the biochemical recurrence-free survival. We can see the overall group, there is a significance between HIFU and the IRP. But in the subgroup analysis, there is comparable result in the intermediate risk group and the high risk group for the PSA biochemical recurrence-free survival. And the salvage treatment-free survival was similar in overall and the intermediate and the high risk between these two groups. The preoperative parameter and the functional outcome comparison is here. We can see that the patients of HIFU experience the shorter operative time and the interval of catheterization and the hospital stay. Moreover, they also experience less blood loss and less blood transfusion rate. But the complication equal the more than grade 3 was similar in the two groups. The postoperative functional outcome, we can see the urethral stricture that need TURP or OIU is higher in the HIFU group with significance. And the urinary incontinence rate is higher in the IRP group. Is about 9.8% with significance. And the epididymitis, which is unique in the HIFU group, decreased after we routinely perform the prophylactic vasectomy. And there is no difference after we changed our strategy for the prophylactic vasectomy. There is no difference between the IRP and the HIFU group. And the de novo erectile dysfunction, although it doesn't reach the significance, but we can see the HIFU group seems to be lower than the IRP group. And if we perform the focal therapy, it will be much lower. And the postoperative IIF-5 was significantly different in the two groups. The HIFU group is more. Here is a discussion. We reviewed studies between the HIFU, whole grain HIFU and the radical prostatectomy. This is a retrospective review in the last year, and the median follow-up duration is about 5 years. The patient selection was the elderly patient, which age is more than 17 years old, and the low to intermediate risk group. And the patient undergo either HIFU or minimally invasive RP, which is laparoscopy RP or IRP. The oncological outcome show that although the HIFU, the salvage treatment free rate of HIFU is lower than the minimal invasive RP, but there is no difference in metastasis-free survival, overall survival, or cancer-specific survival. The functional outcome, the HIFU group showed a better short-term continence outcome, but higher IPSS in 1 year, at 1 year follow-up. The grade 3 or more severe complication was comparable in the two groups. Here are two studies of ours in 2016. We compare the HIFU and the other treatment for localized prostate cancer, including the radical prostatectomy, high-dose rate brachytherapy, cryoablation. The conclusion is that the whole grain HIFU showed non-inferior oncological outcome with radical prostatectomy, but better urinary function improvement and more possible sexual function preservation than the other three treatments. In the current study result, we can see the 2-year oncological outcome, both overall or subgroup analysis was comparable in terms of PSA, biochemical recurrence-free survival, salvage treatment-free survival, metastasis-free survival, and overall survival. But we should very carefully to follow up these patients because the follow-up duration may not longer enough. And the perioperative parameter HIFU shows less time consumption, blood loss, and the blood transfusion rate. In the functional outcomes, urinary incontinence is less than in HIFU, and the de novo erectile dysfunction seems less in HIFU, but the urethral stricture was much more in HIFU. The limitation of this study was first retrospective design and less case of IRP patient, and the learning curve of IRP is also considered because in our hospital the IRP was first performed 3 years ago, so maybe our experience is not mature enough. And the definition of PSA biochemical recurrence was different in IRP and the HIFU. And the oncological outcome, maybe our follow-up duration was not long enough. So here is a conclusion. During the short-term follow-up, the oncological outcome revealed that HIFU showed non-inferior results, even intermediate or high-risk patients. And the perioperative parameter, HIFU seems better than the IRP. And in the complication and functional outcome, HIFU showed less urinary incontinence and more sexual function preservation. But IRP showed less urethral stricture that needs surgical intervention. So in conclusion, HIFU may be served as the bridge between the active surveillance and the radical prostatectomy, and not merely the clinical trial setting or the salvage treatment after RT failure.